This episode was recorded in Q1 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
We think about diabetes in a very different way, and we've tried to bring this across in the GPU, where we're thinking about not only what is the best way to manage glycemia, but also how do we add in the best cardiorenal protection? How do we add benefit for people who are living with type 2 diabetes, but also overweight or obesity? Or how do we help people, say, with other priorities, such as a person with type 2 diabetes living with frailty? So I suppose one of the things that I hope has come through in the GPU is a user-friendly approach to individualising management plans to the person sitting in front of us.
Hello and welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. The college recently published several general practice updates, or GPUs, addressing conditions covered by the CDM programme. We previously covered atrial fibrillation with Dr. Eamon O'Shea, and you can see episode 2 in the show feed if you haven't heard that one yet. And given how well that episode was received, we thought we'd lean into chronic disease management a bit more by making April CDM month. So the plan is to cover 2 more recently published GPUs that relate to the CDM programme in April. We're kicking off today with a 2-part series on type 2 diabetes based on the GPU published in November 2025 with lead author Lisa Devine. Then later in the month, we are going to release another 2-part series, this time on COPD, based on the GPU published in October 25 with lead author Shane McKeough. We'll round things off in April with an episode with Eamon O'Shea and David McConaughey, who discuss implementation and streamlining the operation of opportunistic case finding, the prevention programme and the CDM programme for practices of every size, and provide plenty of pearls along the way. As an aside, we're really thrilled with the initial take-up and feedback from listeners so far, and we're aiming to produce content that delivers quality education material in a convenient format. And with the end of the education year fast approaching, don't forget you can self-record listening to the podcast for work-based learning credits in your e-portfolio. Approximately 1 hour of listening equates to 1 credit. And before we get on to today's show, a quick thank you to everyone who's taken the time to rate, review and provide feedback so far. You can contact us at podcast@icgp with any comments or suggestions you might have for future episodes. And now let's get on with today's show. Kicking off CDM month, as I said, is Dr. Lisa Devine, lead author of the new Type 2 Diabetes GPU. And here's Lisa.
My name is Lisa Devine. I am a GP in Wicklow, and I am also the Irish College of GP and the HSC National Clinical Lead for Diabetes.
As I said, today's episode is part 1 of 2, with the aim of providing a broad overview of the GPU contents, with Lisa providing pearls and key messages as we go along, which I hope GPs at every stage of their careers will find relevant and helpful. Of course, I'd encourage listeners to download the actual GPU itself for the complete picture, and I've included a link in the show notes along with the usual chapter markers and links to other useful resources. Areas covered in today's episode include recent changes in the approach to type 2 diabetes management, focused screening and making the diagnosis, management of prediabetes, and non-pharmacological management options for type 2 diabetes. Then part 2 will pick up the conversation with topics including pharmacological interventions with a focus on individualising therapies, managing other cardiovascular risk factors in type 2 diabetes, potential complications and audit opportunities. So Lisa, would you mind beginning today by reminding listeners just how common type 2 diabetes is in day-to-day general practice?
Yeah, so one of the important things about type 2 diabetes is how common it is. In fact, we know that 1 in 11 adults in Europe is actually living with type 2 diabetes. So when we think about the fact that in a busy general practice day, we could be seeing between 20 and 30 patients, or sometimes even more, in those adults that we're seeing, if we're seeing 20 to 30 patients a day, we're probably seeing between 1 and 3 of that whole group of people who are also living with type 2 diabetes. Now, one fact which I think is really stark and also really concerning is that international data would say to us that 1/3 of people that are living with type 2 diabetes actually are undiagnosed and don't know that they have this condition, and therefore are missing out on the opportunity for early treatment. And we know that, the treatment of type 2 diabetes is of so much benefit. So I always think it's good to keep in mind when we're seeing people, could this person that we're seeing have risk factors for type 2 diabetes? And just keeping an eye out so that we're picking people up as early as possible.
Great, that makes total sense. And just a quick word on the GPU before we go any further, Lisa, because, this format, I say it every time I record a GPU episode, but it's so nice to use in clinical practice. The front page has a jump to section in the lower right-hand corner with links to the really key areas, you might say, that working GPs who are in a busy clinic or in a CDM review can refer to for things like how to individualize the glycemic targets, concepts in the pharmacological management of people living with type 2 diabetes, an algorithm for helping you choose which type of medication is appropriate for the person in front of you based on risk factors, etc. And then some safety aspects to consider as well, all of which, I'm sure many listeners can imagine being incredibly useful, not just for new diagnosis, but also things like CDM reviews. So with that in mind, we're going to move through the GPU in a kind of a systematic way, you might say, from the beginning. And to kick things off, it's interesting you have in your summary on that front page about the paradigm shift that has occurred in the world of diabetes in terms of how to conceptualize it as a clinician.
Yeah, so I suppose one of the interesting challenges about writing this GPU, and firstly, I suppose writing the GPU was not an individual exercise. It involved a whole co-author team and the support of the QSIP committee in the college, and was really based around the questions that GP colleagues would ask me about on a daily basis. So when we kind of created the GPU, we really wanted to make it as user-friendly as possible. One of the big challenges of writing the GPU is we know that in particular in type 2 diabetes care in recent years, the treatment has been evolving and continues to evolve. So we were trying to, I suppose, run alongside a moving train and really find the most up-to-date information and distill it down into, a user-friendly resource for GPs working in clinical practice. One of the big things, I suppose, if we go back 10, 15 years ago, or even a little bit longer, really the management of diabetes was very glucose-centric, and the treatment options that we had available were really quite limited. Whereas now, I suppose, we think about diabetes in a very different way, and we've tried to bring this across in the GPU, where we're thinking about not only what is the best way to manage glycemia, but also how do we add in the best cardiorenal protection? How do we add benefit for people who are living with type 2 diabetes, but also overweight or obesity? Or how do we help people, say, with other priorities, such as a person with type 2 diabetes living with frailty? So I suppose one of the things that I hope has come through in the GPU is a user-friendly approach to individualizing management plans to the person sitting in front of us.
Yeah, and I think it does come through really clearly in the GPU for sure, Lisa. But it is a key concept, isn't it, to move away from the idea of what's the HbA1c number and to take a much broader perspective on that holistic view, but also, on organ systems basically, and the possibility for end organ damage as a consequence. And as you go through in the GPU, there are a number of independent benefits accruing to diabetics based on pharmacological agents that are unrelated to changes in the movement of the HbA1c. Isn't that right?
Yeah, and I know this is something we'll probably talk about in a little bit more detail as we go through, but what you're quite correctly alluding to there, John, is this idea of the addition of cardiorenal protection. And I suppose many people would say, well, what is the story with cardiorenal protection? I know broadly what it means, but what does it actually mean? So I suppose part of this paradigm shift is the fact that we have learned in recent years that certain diabetes medications, namely the GLP-1s and the SGLT2s, have additional benefits for some groups of people living with type 2 diabetes well beyond their ability to improve glycemia. So I suppose in particular, that would be where we use either or both of these medications in people who have a history of things like atherosclerotic cardiovascular disease, or people who may not have that, but they're at high risk of it, people who are living with heart failure or chronic kidney disease. And this is where we add in one of these medications to get benefits kind of independent of glycemia, nearly in the same way as we might add in a statin. So I know we're going to kind of look at that a little bit more further down the line, but I suppose in a nutshell, that's what this whole concept of cardiorenal protection is all about.
Great. And why don't we get into the actual GPU itself at this point, Lisa? And I should just caveat our conversation by specifying that this is not intended as a replacement for the GPU. And I think most listeners would intuitively understand that trying to distill a general practice update on something as broad as type 2 diabetes into a conversation like this would be unrealistic and unreasonable. What we're going to try and achieve today is just to highlight some of the areas that people can expect to find in the GPU if they download it, which I would really recommend, and there'll be a link in the show notes to help you do so. And we're just going to work our way through the document and come up with some pearls as we go. So moving on from the introduction itself then, Lisa, the first section you have here is on screening.
Yes, I suppose we mentioned there a minute ago the fact that internationally a third of people living with type 2 diabetes are actually undiagnosed and unaware that they have this condition. So as GPs, we can really add value if we are keeping an eye out for the risk factors of diabetes. Now, the chronic disease management program really helps us out here because, in fact, many of the risk factors for type 2 diabetes are included in either the opportunistic case finding program or in the prevention program. So specifically, when we think about the OCF visits, so things such as coming from a certain ethnicity, having a history of severe mental illness, having a smoking history, having a body mass index over 30, or having a previous history of chronic kidney disease. These would all be either risk factors or comorbidities that we can see with type 2 diabetes, and they're an indication for that OCF visit. And then even more meaningfully, I suppose, when we think about the indications for the prevention program, actually all of these are risk factors for diabetes. So we have having a history of gestational diabetes, having a raised Q risk, having a history of hypertension, hyperlipidemia, or a history of gestational diabetes. All of these things put us at increased risk of a future diagnosis of diabetes. It's also just worth mentioning, I suppose, that having a history of preeclampsia is also an indication for a prevention program visit, although there's just two little specific pieces there. So I suppose to be eligible for the prevention program, if a woman has a history of either preeclampsia or gestational diabetes, it needs to have been diagnosed after the 1st of January 2023. So that's one just little pernickety bit about that. But really excitingly, both of those groups of people are eligible for the prevention program independent to their card status. So we know that for most of the CDM program, you either have to have a doctor visit card or a medical card, which I think is a little controversial and unfortunate. But in these two groups of people, they're actually eligible for it independent of card status.
Some listeners might be thinking, okay, well, I'm so busy that just trying to keep up to date with my chronic disease management patients is a challenge in and of itself, and to try and add in the OCF and the PP patients as well, and to have clinics for those potentially can be very challenging. And I would just take this opportunity just to signpost people to a conversation I had with David McConaughey and Eamon O'Shea on that very topic about how to set up and implement opportunistic case finding and the prevention program in your practice, regardless of size, in a way that is streamlined and doesn't cost you an abundance of time as a result. But of course, going back to what you said, Lisa, that idea of the underdiagnosis just really strikes to the heart of the importance and the appropriateness of programs like the PP program and the OCF program to try and pick up more cases at an early stage upstream before end organ damage and cardiorenal sequelae occur, etc.
There's no two better men than David and Eamon to talk about that. But I suppose just to add on to that, every GP practice will make this work in the way that suits them best. Because one of the nice things about general practice is it's heterogeneous, and no GP practice will do things exactly the same way. In addition to organising your CDM, I suppose something that I try to keep in mind when I'm seeing people is I'm always wondering, if I'm seeing somebody coming in the door, could this person be eligible for an OCF visit, or should they be enrolled in the prevention program? So you're going to be seeing them anyway. So either if it's user-friendly to do the review or just to arrange the review at that point in time. The other thing that I think is really user-friendly is we're all doing loads of prescription reviews all of the time. If we can link in prescription reviews to a prevention program appointments, I think that's a really good use of our time as well. And of course, just because our self-funding or our private patients aren't covered for this, under the CDM program, I think if we signpost them to the importance of having an annual checkup and try to get them in as well for these reviews, that's really of benefit.
In terms of then that following on from that screening, of course, some people will have potentially pre-diabetes or non-diabetic hyperglycemia. And the criteria for what constitutes or how to diagnose that are on page 2 of the GPU. But for today's conversation, rather than going too much into the nitty-gritty of diagnostic criteria, we might move on just to the management of pre-diabetes, please.
Yeah, so I suppose, so exactly as you've said there, we won't get too bogged down in the diagnostic criteria because we have that available on page 2 there of the GPU. There's 2 important things to keep in mind once we've made a diagnosis of pre-diabetes or non-diabetic hyperglycemia, as the World Health Organization likes to call it nowadays. But that is, I suppose, the fact that there is an increased risk with this condition of future type 2 diabetes, but also there is increased cardiovascular risk associated with prediabetes and an increased risk of all-cause mortality. So the important thing is signing the person up to the CDM prevention program. But then there's another type of prevention program we need to think about as well. And this is the HSC, dietitian-led diabetes prevention program, which hopefully is available via referral to your local integrated care hub. And what this is, it's a really nice program actually, delivered over about 12 months or so. Several group sessions focusing on things like lifestyle change, behavioural change. And actually, this program has been shown to have fantastic results. So one of the pilot reports into the program showed more than 75% of patients lost weight with this. 50% of them went back to having normal glycemia, which is fantastic, and really positive patient feedback. So it's very, very worthwhile referring on to the dietitian-led HSC diabetes prevention program. Then I suppose there is this slightly controversial area. So usually we don't put people onto specific medication for pre-diabetes, unless maybe they're floating up to the higher end of the HbA1c. So they're getting closer and closer to having diabetes, and they've really tried all of the lifestyle interventions, or maybe for some reason they're not able to partake in lifestyle interventions and they would like to try some medication. In that situation, sometimes using a little bit of metformin is perfectly reasonable as well.
I will say, Lisa, that those dietitian intervention outcomes are heartening, because it can be easy to kind of get to a bit of inertia in your practice and think, well, do the lifestyle interventions really make a difference, but of course they do, and they're really fundamental to all of these prevention strategies and management strategies, and it's worth keeping them at the centre of the focus. So thanks for that. So aside from those lifestyle interventions, Lisa, and aside from that idea of potentially adding metformin, there are other pharmacological strategies available to us now as well, aren't there?
Yes, I suppose it's interesting when we think about prediabetes. Of course, we're thinking about the person as a whole, and many people with prediabetes may also be living with obesity. And just one other thing to mention is the fact that when it comes to the weight management product for the weight management form of liraglutide, which is known as Saxenda, actually having prediabetes is one of the criteria for reimbursement. So just it's something to keep in our minds. So while this isn't a specific treatment for pre-diabetes, for our patients that are living with obesity, pre-diabetes is one of those reimbursement criteria for Saxenda, along with being aged 18 to 74, having a body mass index over 35 kilograms per meter squared, having pre-diabetes, as we mentioned just there, having participated in non-pharmacological interventions, and having other markers of high risk of cardiovascular disease. And there is more information on that via the Medicines Management Programme. So it's just one of those things that's worth keeping in mind. And it is one of those places where the management of obesity, which is obviously very vast, and the management of pre-diabetes can overlap a little bit. And I know we're going to talk further in episode 2 about the management of diabetes, where overweight or obesity is the priority for the patient.
So that's the pre-diabetes piece. And then moving on to the actual diagnosis again, the criteria are in the guidelines. But could you maybe start with an approach to when somebody does meet the diagnostic criteria, please?
Yes, I suppose there's a couple of little points. So I think we are all well used to, at this point, diagnosing type 2 diabetes. So I imagine when people are listening in, they're just going to be doing a little bit of a mental tick off in their head of all the things that they already know. So we know, so the diagnostic criteria for type 2 diabetes are in the GPU. We know that we can diagnose it, several different ways, with the most common one being the HbA1c. One little practice point is it is important to repeat the test. So say we do a HbA1c, it comes back as being 48 millimoles per mole or 6.5% or above. And it is really important that we do repeat that test just to confirm the diagnosis. So that is the recommendation. And I suppose it is a significant lifelong condition, as well as just repeating that diagnostic test. Sometimes people might say, if I do one diagnostic test, should I do a different one? So if I did HbA1c this time, should I do glucose next time? The answer to that is no. You're better to stick with the same one to avoid any confusion. So that's just one little question that sometimes people would ask. The other thing, I suppose, to keep in mind, the HbA1c is a really convenient and very good diagnostic test. It gives us an idea of how glycemic control has been over the last 3 months or so. But there are a couple of there are a few situations where we shouldn't use the HbA1c. So just that's the only other thing to keep in mind. So we shouldn't use it in pregnancy. We shouldn't use it in people who are acutely unwell, because it gives us an idea of glycemic control over 3 months. If there's a dramatic shift, it's not great in that situation. And at the moment, it's not used in children or adolescents, although that might change in the future. The other thing, I suppose, is the HbA1c is strongly reliant on the hemoglobin molecule. So the hemoglobin A molecule, really kind of what we're measuring when we do HbA1c is how much glucose is stuck to that hemoglobin A. So things that affect the red cell can sometimes affect the validity of our HbA1c. So things like different anemias, having had a recent transfusion, and then certain medications, such as certain treatments for HIV, certain medications such as dapsone can throw off our HbA1c. So if we're using HbA1c in these groups of people for either diagnosis or monitoring, we might want to think again and have a look at one of our other methods of diagnosis or monitoring.
Great. And The next useful point for me in the GPU, Lisa, is the idea that, before you move on to the management steps when diagnosis is made, is maybe to take a pause, stop and think about certain cohorts who may need an immediate onward referral to secondary care.
Yes, I suppose by far the most common type of diabetes we're going to come across in general practice is type 2 diabetes. And if it looks like a duck and it quacks like a duck, it's a duck. There are just a few little clinical practice points that we want to kind of keep an eye out for. So those kind of zebras that we think about sometimes. So keeping an eye out for either type 1 diabetes or latent autoimmune diabetes in adults, previously known as LADA, is important. It's not very common. I think I've maybe seen 2 cases in my whole career presenting into general practice, but of adults coming in where we think maybe it's type 2, but actually it turns out to be type 1. There's a couple of little clinical features we should keep an eye out for. So considering younger people coming in, clinically, if a person comes in, if they're more unwell, if they've had rapid weight loss, in particular, if they have a lower body mass index, or if they have a history of autoimmune conditions, or there's a strong family history of autoimmune conditions, we need to just have a little bit of an eye on, listen, this person maybe isn't the typical person with type 2 diabetes. Could there be another type? One really important thing is if a person is acutely unwell or if they have a lot of those osmotic kind of symptoms, just grabbing a quick urine off them, checking for ketones, that you don't have somebody who has a new diagnosis of type 1 diabetes and they're actually walking in the door to you in DKA. So that's something to keep in mind. And then the other thing is this whole piece of LADA. So LADA is a really interesting condition where initially a person presents for all the world looking like they have type 2 diabetes, and then over time their pancreatic function reduces, drops off a cliff, and all of a sudden they come in and it turns out that they have a type 1, more of a kind of a type 1 picture. So just keeping an eye out for some of those symptoms is really important. And if in doubt, just check a urinary ketones. And if we're in doubt about diagnosis, getting that specialist opinion either via the hub or the hospital. It's worth saying that if we have a person acutely unwell with a new diagnosis of diabetes and we think that they have either type 1 or LADA, we may well be sending them in to the hospital. Really they need that kind of urgent attention. The other thing to keep in mind is younger people who are presenting with a new diagnosis of type 2 diabetes. And this is a very interesting group. Traditionally, people who were under the age of 40 presenting with new diabetes rarely had type 2 diabetes. As we are seeing a rise of people living with overweight or obesity, interestingly enough, we're seeing more young people with type 2 diabetes. But we do need to consider other forms of diabetes in this group, like your type 1, and then also the likes of your monogenic diabetes, so your genetic kinds of diabetes. So if we have a person and they're well, and we have a new diagnosis of diabetes under the age of 40, we don't think that they have type 1 and that they need to go to the hospital or LADA. And we do still need to get them seen by our specialist colleagues just to find out what type of diabetes they have. And if they do end up with a diagnosis of type 2 diabetes, this group really need early aggressive treatment of their diabetes and aggressive cardiovascular risk factor management. So they're just a group not to keep in our practice. They should go off, get some specialist input, and probably absolutely come back to us if they have type 2, but they do need a different type of input. The other, I suppose, little diagnostic thing to keep in mind is this whole idea of pancreatic diabetes. So we're reliant on our pancreas to make insulin. So it stands to reason that anything which affects our pancreas can also cause diabetes. So one thing to keep in mind is that new onset diabetes can be a red flag for pancreatic cancer. In fact, up to 1% of adults with new onset type 2 diabetes develop pancreatic cancer within 3 years. and 1 in 4 people with pancreatic cancer have diabetes. Now, we don't need to be afraid of this, but what we do need to keep in mind is the NICE guidelines on the recognition of cancer, which suggest considering an urgent direct access CT scan or urgent ultrasound scan if we have people who are over the age of 60 with newly diagnosed diabetes and weight loss. The other thing that it's important to keep an eye out for in this group of patients will be things like back pain or upper GI symptoms, that type of thing. So while we don't want to make anybody alarmed, it is just, I suppose it's that zebra presentation as well, seeing diabetes with new unexplained weight loss, if a person doesn't have type 1, is a little bit atypical and we need to think further on it.
Thanks for those really important points, Lisa, and certainly worth keeping in the back of your mind in terms of the different categories and what to consider in each cohort. And one thing that just pricked up my ears was around that younger person and the need for aggressive therapeutic strategies in those cases, which brings me neatly on to page 5 of the GPU, which is where you outline a table of individualizing glycemic targets in different groups. Now, again, we're not going to exhaustively go through the table, but before we move on to non-pharmacological management options for our type 2 diabetic patients, are there any little pearls that you'd like to pick out or provide an overview around those individualized glycemic targets?
Yes, I suppose it's interesting. A common theme of the GPU is individualising care. Individualising the pharmacological management is one part of it. And then I suppose looking at individualised glycemic targets is another piece, because we do know that in terms of achieving the best outcomes for the patient, it's not a one size fits all. There are lots of different factors that we need to consider, and I hope that the table in the GPU just makes it a little bit easy. I suppose most guidelines would suggest, and what we've kind of mentioned in the GPU, is that for most healthy, non-pregnant adults, we might be looking at a target HbA1c of less than 53 millimoles per mole, or that's 7%. However, those younger patients, those younger people living with type 2 diabetes, we may well be looking at slightly tighter control, even less than 48 millimoles per mole. And I suppose that's really people who are probably that bit younger, with a shorter duration of diabetes, relatively few comorbidities, are keen to take this approach themselves. And if we can achieve it for them without putting them at risk of adverse drug reactions or hypoglycemia, that's ideal. And then the other thing just to consider, I suppose, a lot of our patients that we see with diabetes might also be older adults. And we know that if we go for really tight glycemic control in older adults, we can actually put them at risk of adverse drug reactions, hypoglycemia, falls, hospitalizations, even mortality. And I won't go into it in too much detail, but we have kind of summarized the American Diabetes Association's approach to individualizing the target HbA1c in different groups of older adults, because we know that they're very heterogeneous. So that's worth a look if you just want to have a little look at how can you pick the best glycemic target for your patient. That's worth a review.
Great. And just to reiterate, that is on page 5 of the GPU for people to take a look at that table themselves. And then that brings us on to management strategies, starting with the non-pharmacological management strategies for our diabetic cohorts. So could we start there, please?
Yes, I suppose the first thing to say is a diagnosis of type 2 diabetes is a really big event in a person's life. Many people, when they think about type 2 diabetes, might remember a relative who lost their sight, perhaps even had an amputation. It can be really frightening for people. So I suppose acknowledging that is the first bit. We know that we know that knowledge is power when it comes to type 2 diabetes management. And so the first thing that I would say is that whenever we diagnose a person with type 2 diabetes, we want to give them the opportunity to attend for diabetes self-management, education and support. And for this, I'm talking about Discover Diabetes, which is the structured education program for type 2 diabetes. And touch wood, you should be able to refer to that through your local hub. One thing that you may not be aware of is that some people, for different reasons, may not be suitable to attend group education. And in that situation, we can actually still refer for one-to-one dietitian support via the hub. So it doesn't have to be a punitive thing. We don't have to force people into situations they're not comfortable with. The support can match the person's characteristics and preferences as well, which is really important. After that, I suppose two of the key components. So we're thinking not only about diabetes, but we're thinking about overall cardiovascular health. Physical activity is of huge benefit, both for type 2 diabetes and overall cardiovascular health. Now, the ideal situation is if a person can get in at least 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise per week. That's gold star. That's fantastic. But how many people can manage that on a week-to-week basis? I don't know if you can manage it, John, but I certainly struggle to manage that. So while we want to obviously let people know this information, actually small changes in lifestyle can make an equally powerful impact. So things even like saying to a person, even a half an hour of exercise a week is associated with metabolic benefits. A particularly favoured one, because you can kind of link it to getting off the bus, even a stop early. So an increase of 500 walking steps a day is associated with a 2 to 9% reduction in cardiovascular morbidity and all-cause mortality. Like, that's really powerful.
And could I just chime in there and say the same thing? I was really struck by that piece of information, that you can share that with any patient. And, most people are, it's well within their gift to put in 500 steps a day, because sometimes I feel like it's really useful to hear you, talk about the public health idea of 30 minutes of exercise a day. But sometimes I get the sense that patients are only waiting for me to drop in a flyer from the local triathlon club. It's so divorced from the reality of their lives, whereas these small measures have huge data behind them, don't they, in terms of their benefit?
Absolutely. And I mean, I think this is it. I think traditionally, and from talking to people living with type 2 diabetes, sometimes that initial communication piece really felt like it was full of a list of jobs and very punitive. You must do this, you must do that. Whereas in fact, we know now that it's much more of a team approach and encouraging people to find the thing that works for them. And, small gains are better than perfection. Perfection is fantastic, but who can achieve perfection? So there's a full list of kind of the information on those little changes available in the GPU. The other thing that might be popular to say to people is getting a good sleep. So 6 to 8 hours of good quality sleep, getting rid of the screens, getting a nice bit of sleep actually has improvements. That can have improvements in glycemic control as well. So that's another popular one that we can mention. And then I suppose the next thing is that dietary advice. So, I mean, it's a veritable quagmire out there, isn't it? Of, information that we are presented with on a daily basis from lots of different sources about different diets. And we have to remember that we're living in the same ecosystem as our patients. Being able to provide, just even some basic tips ourselves can be helpful. And then the diabetes self-management education and support goes into a lot more detail on the dietary piece. But in general, it's really sensible stuff. So it's regular meals, adequate hydration, having a broad kind of a diet with, trying to minimize the extremely processed food, having moderate portions of unprocessed high fiber food like vegetable, fruit, getting in your lean proteins, trying to get in your unsaturated fats such as your olive and rapeseed oils, trying to minimize your treats, your really high sugar stuff. So I suppose it's really that common sense stuff. The other thing that I would say, there's just one little hazard that I would point out, and that's around this idea of the keto diet or the extremely low calorie diets. Just in some people with diabetes, especially those at risk of either hypoglycemia or those on an SGLT2 inhibitor, we have to, I suppose, just give measured advice to people about that and say that maybe those diets wouldn't be the best because of the risk of either hypoglycemia or increased risks of things like euglycemic DKA. But I suppose really when it comes to lifestyle, it's all about giving advice that fits the person, common sense, encouraging advice, and signposting that diabetes self-management education and support.
Great. You also emphasise, of course, the importance of smoking cessation, one to always be kept in mind, and really that's, of course, a huge intervention that can have a positive impact on patient lives. And I thought it was really useful that you also mentioned the potential mental health implications for diabetes, like so many of these chronic illnesses, but you had some interesting data there as well, which is really important, isn't it, when we're reviewing our patients, to check in with them from a mental health perspective too?
Yeah, so diabetes, type 2 diabetes rarely exists in a vacuum. And I can signpost to an upcoming blended e-learning module that we're going to be launching in May from the college, which is going to look at the management of multimorbidity in people with type 2 diabetes. But just coming back, and that's going to look in a bit more detail about mental health and incorporating comorbidities and multiple long-term conditions into management. But I suppose we know that many people living with type 2 diabetes are actually also struggling with mental health, and it's kind of a bi-directional relationship. Depression is increased by 40% in people living with type 2 diabetes, and about 1 in 5 people living with type 2 diabetes will also have anxiety. There's also these kind of specific diabetes related mental health issues that we can see. So this idea of diabetes distress, which is a very specific mental health distress that people can feel literally related to the diagnosis and the burdens it placed on them. And we spoke about that a little bit already. And then diabetes burnout, which is a sense of frustration and hopelessness, again, by fears around the condition and all of the things that we, ask patients to do to manage this condition. So I think, listen, I'm not going to sit here and tell GPs how to manage mental health related conditions. This is part of our bread and butter. But I suppose something to keep in mind is just maybe if things are gone wrong in terms of the diabetes care, the mental health can sometimes be the key.
Many thanks to Dr. Lisa Devine for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources. The next episode to arrive in your feed will be part 2 of this conversation. Thanks again for all the support to date, and again, please feel free to get in touch by contacting us at podcast@icgp.ie. And that's it for today's show. Many thanks for listening, and until next time, take care.